Many thanks for the trainees joined in our YouTube channel to revise the testicular cancer in preparation for urology exit exams. Thank you for the trainee who has given the consent to record the session so that it will be a good revision tool. The one other thing is closer to the exam, try to relax more and try to sleep more, because it's very important that you should get enough recollections during the exam. I think sleeping is a very, very good one. And if you are not a heavy coffee or tea drinker, don't indulge and try to be free of caffeine. And if you are a good coffee drinker, no way you can change in this short time. Just keep the routine practice. And the other thing is, during the exam, since you have discussed so many sessions with us, try to behave as if you are talking to us, even though the examiner will be of a different stature and different vocal modality, and then they are in face to face. Imagine as if you are talking to me or Anish. So that will make you really a very nice, calm approach, and that will really help you.
Yeah, absolutely.
Yeah. And thank you for Anish for preparing the slides which will be used in the YouTube recording in the background, so that you can go back and revise some values also. Okay?
Yeah.
Good. Your time starts now. You have a 33-year-old gentleman presents with history of left-sided testicular lump found during taking bath. How are you going to evaluate him?
So I will see him urgently in a 2-week wait clinic with a cancer nurse specialist, where I will take a history, examine the patient, and arrange some tests. In my history, I will establish the duration of this lump, if it's painful or painless, if it's increased in size. I'll ask about history of trauma to the testicle, any associated urinary tract infection or sexually transmitted infection in the recent past. I'll ask about risk factors for testicular cancer, including past history of testicular cancer, family history of testicular cancer, and history of undescended testicle. I'll ask about symptoms of advanced disease, such as weight loss or coughing or breathlessness. I will then document this patient's past medical history, including drug history. And I'll ask also about if he's got children or if he wants to have a family. Following on from this, I will offer a chaperone and examine the patient, general examination, feeling for any abdominal palpable masses or supraclavicular lymph nodes. I will focus on the genitalia, examining the normal testicle and then the abnormal testicle, localizing the lump, size, site, and any tenderness. Following on from this, I will organize an urgent ultrasound. I'll walk this patient down to radiology departments for an ultrasound scan of a testicle to confirm a suspicious mass. I'll also take some bloods, including football count, using his liver function test, testicular tumor markers, LDH, AFP, beta HCG. And depending on the results, I will counsel the patient appropriately.
Okay. What are the risk factors for testicular cancer?
So the risk factors include risk of undescended testicle, previous history of testicular cancer, family history of testicular cancer, maternal use of steroids during pregnancy, which is difficult to quantify or elicit in the history. There is also association with low fertility with testicular cancer.
Okay. What is the prevalence of testicular cancer in the community?
So the prevalence of testicular cancer is about 1 to 2%.
Okay. And what is the usual age incidence?
So the age incidence depends on the histological type. So for seminomas, it's usually in the 4th decade. For non-seminomas, it's usually in the 3rd decade. So 20s to 30s for non-seminomas, 30s to 40s for seminomas.
Okay, the scan findings showed a possible left side testicular lump measuring 2.3 centimeters. The right testis is normal. How are you going to proceed?
So this is suspicious of a testicular tumor. I will, in the presence of a cancer net specialist, explain my concern to this patient that there is a lesion suspicious of testicular cancer. And the way to manage this would be to perform an operation in the form of a radical inguinal orchiectomy to remove the testicle, but also to confirm histologically that this is a testicular tumor. I will arrange for this ultrasound to be reviewed in MDT, and I would also offer this patient, if he agrees to an orchiectomy, a prosthesis, testicular prosthesis, as well as sperm banking.
Any other imaging necessary?
I will stage this patient as well with a CT, thorax, abdomen, and pelvis.
Any particular patients who require cerebral imaging like CT scans?
So if the patient presents with any neurological symptoms, or if there's a concern of choriocarcinoma, then this patient will warrant a CT head.
When will you suspect choriocarcinoma?
So very, very raised levels of beta HCG will make me suspect choriocarcinoma.
Any role for MRI scans?
So MRI scan is not routinely used in the assessment of testicular lumps. It could be used, but ultrasound is over 99% sensitive, easier to get and cheaper to acquire. So in my practice, I will go for an ultrasound rather than an MRI scan, which usually is logistically difficult to arrange.
Any role for FDG PET?
So FDG PET is used in the for metastatic disease, especially for seminomas, during the follow-up, if there is residual mass following chemotherapy.
Any role for bone scan?
So bone scan is not routinely used in the assessment of testicular cancer. However, if there is any suggestion of bony pain that warrants further evaluation, then a bone scan may be used.
Okay. What do you know about serum tumor markers? What is the importance, and how do you differentiate with the markers? What is the primary tumor?
So serum tumor markers are useful for both diagnostic and prognostic assessment of patients with testicular cancer. From a diagnostic point of view, certain tumor markers will likely correlate with certain types of testicular cancer. For instance, we know that pure seminomas do not elaborate alpha-fetoprotein. 10% of them may elaborate beta HCG. We know that 100% of choriocarcinomas will elaborate beta HCG, and also non-seminomas will elaborate a combination of HCG and alpha-fetoprotein in up to 90% of the cases. So this is useful from a diagnostic point of view. From a prognostic point of view, post-orchiectomy tumor markers will help in staging of testicular cancer, depending on the levels of these tumor markers.
What is the importance of elevated LDH?
So LDH is mainly an indicator of tumor bulk. It's not specific for any of the testicular tumors.
Okay. What do you know about the half-life of tumor markers and why they are important?
So the half-life of tumor markers are as follows. Beta HCG is 24 to 36 hours. Alpha-fetoprotein is around about 5 days, and LDH is 24 hours.
Okay.
The importance of this is that if clinically one suspect a stage 1 testicular cancer, then following orchiectomy, you'd expect a significant drop in the tumor marker levels a week after orchiectomy. If there is persistence or rise in tumor markers, then one will worry about metastatic disease or even disease in the contralateral testis.
Okay. You said you will do orchiectomy for this gentleman and also offer testicular prosthesis if he is interested in that. Is
Yes.
there any role for sperm cryopreservation?
The EAU guideline recommends that we offer patients sperm banking, preoperative sperm banking before orchiectomy. The purpose is to cryopreserve the semen for use in assisted fertilization down the line. So I'll offer this to the patients, and to prepare the patient for sperm banking, I'll explain that pre-semen specimen needs to be submitted with 2 to 3 days of abstinence. Patient needs to also have bloods, screening tests for HIV 1 and 2, hepatitis B, and hepatitis C.
Okay. How long the sperms will be preserved?
So the sperm will be preserved for 10 years, and the first year will be funded by the NHS and subsequently funded by the patient at a cost of £200 per year.
Okay. Why do you want to do HIV and HPSAG battery of test before sperm cryopreservation?
So the importance of this is to determine where the sperm will be stored. If they're HIV positive, they will go to a special sperm bank. If they're not, they will go to the general sperm bank.
Okay, we'll stop there. It's 10 minutes now. Any questions from yourself before I give the feedback?
I think I progressed well. I answered the question. I'm not sure if I got to the end of the scenario, but
yes, I mean, in the exam, the testicular cancer will be almost like just one scenario. That's it.
Okay.
There is not much divisions like evaluation for initial testicular cancer, seminoma, non-seminoma. There is not much differences. For example, testicular prostheses, they may not even ask much in the testicular cancer table. They may ask it maybe in technology table and otherwise. But since we are revising, I just want to rope in everything so that by chance if the examiner dwells in any particular question, you should be able to come out unscratched.
Okay.
So don't worry about completing the scenario, but in your space is good. I'm sure in real life you will be completing the scenario comfortably.
Okay. Thank you.
Yeah, and just to give you a little bit of feedback so that the questions will be much more complete. The answers are complete, but how to make it much more complete. So surgery in the genitalia during the examination or in the history, you can concentrate surgery in genitalia because any scars due to previous hydrocele or hernia repair could interfere with your surgery and also could warn you regarding the absence of the proper lymphatic drainage anatomy.
Okay.
And in the risk factors for testicular cancers, previous history of intratubular germ cell neoplasia is one of the risk factors.
Very important. Yeah.
And while discussing the prevalence of cancers in the community, the 1 to 2% what you said is only for bilateral testicular tumors.
Okay.
And the role for MRI, whenever a patient is not suitable for ultrasound, that's the same answer you will give for patients like those who are like pregnant patients or patients who are not very conclusive with ultrasound diagnosis. So if the ultrasound diagnosis is not conclusive, there is a role for MRI. So MRI will be always the fallback if the ultrasound is not conclusive. And FTG PET is good in seminoma, but if the lesion in the CT scan should be more than 3 centimeters. And bone scan, as you said, there is no role for bone scan in testicular tumor staging. If you look into the TNM staging also, in the metastasis, there is no place for bone metastasis. And sperm cryopreservation, it's 10 years or 55 years of age. Say for example, if you find a tumor in a patient who is 50 years, we can't preserve till 60 years. So 55 years is the maximum. But in general, since the patients are, as you said, third decade or fourth decade, 10 years of sperm cryopreservation is available in NHS.
Okay.
Well done. can we continue to the next scenario?
Yes, please.
Yeah, your time starts now. What are all the indications for testis sparing surgery when you're dealing with testicular cancers?
So the indications for testis sparing surgery would include a solitary testicle for any reason, such as someone who's had previous contralateral orchiectomy and presenting with tumor in the residual testis. So this would be the main indication for testis preserving surgery. If also there's suspicion that ultrasound findings are not clearly confirmatory, then testis preserving surgery could also be considered.
Okay. Take me through insertion of testicular prosthesis. You have finished your orchiectomy.
Okay, so my considerations and my approach to testicular prosthesis insertion is that this is a prosthesis insertion with a potential risk of infection. So I will limit the number of patients in theater, ensure that this is done in a laminar flow theater, and that everyone has appropriate PPE and masks on. I will use a non-touch technique and impregnate the prosthesis in betadine or gentamicin antibiotics. To select the size of a prosthesis, I will roughly measure the contralateral testis to gauge an appropriate size. Patients should have had antibiotic prophylaxis as part of intraoperative induction. Following on from that, I will introduce the prosthesis and anchor the prosthesis to the dependent or fundus of the scrotum with a non-absorbable suture. I will then close the bladder neck to avoid proximal migration of the prosthesis.
Okay, what do the prostheses are made of?
So they're made of silicone.
Okay, and how are you going to fix the prosthesis in the main fundus of the scrotum?
So there is an anchor on the prosthesis, which I will backfeed my suture, non-absorbable suture, maybe number 4 proline or number 3 proline, and anchor that to the fundus of the scrotum and tie that down, and then reduce the prosthesis down to the scrotum and close the scrotum neck.
Okay, what are all the indications for contralateral testis biopsy?
According to the EAU guidelines, the indications for contralateral testis biopsy will be a patient less than 40 years with a small testicular volume less than 12 mils. This should also be considered in patient with poor sperm parameters, as well as patient with a history of undescended testis on the contralateral side.
So what are you planning to find in the opposite testis?
The main thing of concern in the contralateral testis is intratubular germ cell neoplasia, which coexists in about 5% of testicular cancers. However, with the risk factors, this can go up to 35%, hence the need to biopsy.
Okay, how will you histologically classify testicular cancers?
So according to the WHO classification, testicular cancers can be classified as seminomas, spermatocytic seminomas, and non-seminomatous germ cell tumors, which would include teratoma, embryonal cancer with teratoma, pure embryonal cancer, yolk sac tumor, choriocarcinoma, and then the non-germ cell tumors such as Leydig cell tumor, Sertoli cell tumor, and lymphomas.
Okay. Could you explain the TNM classification for testicular cancers?
So the TNM classification for testicular cancer is as follows. TX, tumor cannot be assessed. TIS, intratubular germ cell neoplasia. T1 is tumor involving the testis with no lymphovascular invasion and no invasion of the tunica vaginalis. T2 is lymphovascular invasion or tunica vaginalis invasion. T3 is tumor involving the spermatic cord, and T4 is invasion of the scrotum. NX cannot be assessed. N0 no lymph node mets. N1 is single or multiple lymph nodes less than or up to 2 centimeters. N2 single or multiple lymph nodes 2 to 5 centimeters, and M3 more than 5 centimeters. MX mets cannot be assessed. M0 no mets. M1 A is metastasis to the chest lymph to the mediastinal lymph nodes or lung metastasis, and M1B is non-pulmonary visceral mets.
What about the S staging?
There is the S classification as well, taking into consideration the tumor markers. So S1 is LDH less than 1.5, upper limit of normal, beta HCG less than 5,000, and AFP less than 1,000. S2 is 1.5 to 10 times for LDH, 5,000 to 50,000 for HCG, and 1 to 10,000 for AFP. And S3 is levels above S2.
Okay. What is the predictors for relapse in seminoma and non-seminoma?
So the histological predictors for relapse in seminoma include tumor size more than 4 centimeter and invasion of the rectal testis. For non-seminomas, this include lymphovascular invasion, presence of embryonal components more than 50%, and proliferation more than 70%.
Okay. If there is a biopsy showing germ cell neoplasia in situ, what is your approach?
So it's important to explain to the patient that with the presence of ITG-CM, there is a 50% chance of progression to invasive cancer in 5 years. So I will explain this to the patient. However, patient can be, the management options would include surveillance or radiotherapy to the contralateral testis.
Will the testis being solitary testis or presence of contralateral normal testis affect your decision making?
So it would affect my decision making in that if it's solitary testis and the patient, for instance, wants to have a family, they can be encouraged to defer any treatments and go have a family with close supervision and self-examination, and then to consider treatment after that. So this will affect my decision making. Yes.
Okay. If it is opposite is normal, what's your plan?
If the opposite is normal and it's just germ cell neoplasia in the solitary testis, then the option can be expanded to include an orchiectomy on that side.
Okay. Let us assume that your patient has got histology of seminoma 3 centimeters and histology shows no rete testis invasion. What is your treatment plan?
So this patient, given these histological features, has about 6 to 12% risk of developing retroperitoneal mets down the line, compared to 32% of patients who have the risk factors present. So I will explain to the patient the management options, which would include surveillance or a single shot of carboplatin.
Okay. How will you dose the carboplatin?
So carboplatin is calculated using area under the curve to come up to 7 milligrams per mil.
What do you mean by the area under the curve?
So it's calculated. I'm not exactly sure of the details, but it is a graph which is extrapolated to work out the appropriate dosing, which will give the area under the curve of 7 milligrams of body weight.
Okay, good. We have finished 10 minutes. I'll give the feedback and then we'll discuss further. So area under the curve is kind of plotting of blood concentration in the y-axis, and in the x-axis there will be time. So all we want is a particular concentration of the carboplatin. We are trying to maintain the carboplatin to extend up to that particular value of 7 area under the curve. It depends upon the individual patient, because if a patient's renal excretion is excellent, you may have to increase the dose. If the patient's got low EGFR, with low dose they will achieve better area under the curve. And it is a computer generated curve, and the dose, actual dose milligrams, will depends upon the patient's excretory status, age, body mass index, etc.
Thank you.
Taking you back through the starting of this scenario, testis preserving surgery, you can think in if there is a suspicion of the benign tumors, and also for synchronous and metachronous bilateral tumors, not only the solitary tumors. And if there is a need, you may have to do a kind of invagination of the scrotal skin into the inguinal incision, so that you can fix the testicular processes comfortably, and then take the processes into that and then close the bladder neck. For WHO classification in N2, the size of the node is not only between 2 centimeter to 5 centimeter, also the number of lymph nodes less than 5, that is also included. If you look quite diligently, the number of lymph nodes should also less than 5, not only the size. And for germ cell neoplasia in situ, for solitary testes, radiotherapy, the dose is 20 gray in the fraction of 2 grays per fraction. So these are a little bit here and there, so that the answers look more better, and then you can try to get the maximum out of the testicular cancer table, because this table is the one where it's very easy to score complete mark. There is no deviations, there is no need to bring any big references or articles. If at all, if you bring EAU 2021 guidelines here and there, that's more than enough. Isn't it?
Thanks.
Okay, good. Happy to start on the scenario?
Yes, please.
Okay, your time starts now. Regarding clinical stage 1 seminoma, what are all the treatment options available?
So for clinical stage 1 seminoma, treatment options following radical orchiectomy would include surveillance or administering a single dose of carboplatin to reduce recurrence. There's also the option of retroperitoneal radiotherapy with 20 grays, but we don't routinely do that in the UK.
Okay, what about stage 1 non-seminomatous germ cell tumor?
So for stage 1 NSGCT, the options are single course of BEP, bleomycin, etoposide, and cisplatin, or surveillance, or upfront RPL&D, which again we don't routinely practice in the UK.
Any specific histology factor which will influence the patient's prognosis?
So the histological factors for seminomas will include tumor size more than 4 centimeters, as well as retotestis invasion. For non-seminomas, it would include lymphovascular invasion, embryonal elements more than 50%, or proliferation more than 70%.
For a patient who decides to have RPLND for stage 1 non-seminomatous tumor, what is the prognosis and what is the main outcomes?
So this is major surgery, needs to be explained to the patients. This will also be diagnostic in terms of full staging. If, for instance, this lymph nodes yield active tumor cells, in which case the patient will then require chemotherapy. With regards to the risks of complication, there is up to a 20% risk of morbidity associated with this. Risks include major bleeding from abdominal vessels, chylous peritonitis, as well as anejaculation if the sympathetic chain or hypogastric plexus is affected. So this needs to be explained carefully to the patient.
Any histology found in the testes will make you to go for primary RPLND and not to choose surveillance or any chemotherapy.
I think if a mature teratoma is seen, that will not be radio or chemosensitive, so that may be an indication for primary RPLND.
Okay. What is the treatment for stage 2A and B seminoma?
So stage 2 A and B will stage 2A?
Yeah.
I'm not exactly sure.
Okay, stage 2A, say for example, lymph nodes less than 2 centimeters. Normal markers.
Lymph node stage. Oh, I see. Okay. So lymph node stage. So N2. I'm still not very clear on the question. Sorry.
Okay. The lymph nodes less than 2 centimeters, markers were normal. Seminoma is the primary histology from the testes.
Oh, right. Okay. So in terms of the clinical staging. So for stage 2A, seminoma, this will fall into the good prognosis group for the IG-CCG category. So the patients will require 3 courses of BEP, or if there are contraindications to giving bleomycin, then patients can have 3 courses of cisplatin, ifosfamide, and etoposide.
Okay. So what will be your choice if it is the same stage 2 but the primary histology is non-seminomatous germ cell tumors?
So that will also fall into the good prognosis for non-cell NSGCT. So the treatment again will be 3 courses of BEP.
Okay. What is the treatment for metastatic germ cell tumor? Let us assume that initial staging itself showed pulmonary metastasis.
So in the presence of, can I just clarify, is this for seminoma or non-seminoma?
Seminoma.
Okay, so if there's a pulmonary metastasis in seminoma, in the absence of any visceral mets, this would again fall into the good prognostic group. And so the treatment option will be 3 cycles of BEP.
How will you differentiate this prognostic group? What is the criteria?
So the International Germ Cell Cancer Collaborative Group for seminomas has classified them into good and intermediate prognosis, and there's no bad prognosis for seminoma. And the factors taken into consideration in terms of histology or metastasis is the presence of non-pulmonary visceral mets makes the patient an intermediate prognosis for seminomas, whereas everything else falls into good prognosis. For non-seminomas, there's good, intermediate, and poor prognosis. Histologically, if the primary tumor is in the retroperitoneum or in the testis, that will be a good prognosis. If the primary tumor is in the mediastinum, but there's no visceral mets, then this is intermediate group. If there is extrapulmonary visceral mets, then this would be poor prognosis. Also, the S category comes into place as well. So S1 will be good, S2 will be intermediate, and S3 will be poor.
Okay. In clinical stage 1, yes, tumors, and the ultrasound examination of the opposite testis and repeat imaging, everything is stable, there is opposite testis normal, and the tumor markers are just slightly elevated. What is your follow-up?
So with raised tumor markers, one worries of presence of retroperitoneal or lymph node mets, and so full staging CT will need to be reassessed at MDT, and considerations would either be to give chemotherapy,
Okay.
depending on the CT findings.
Okay, what is your treatment protocol for seminoma patients with retroperitoneal residual masses more than 3 centimeters?
So for seminoma patients with retroperitoneal mass more than 3 centimeters, one is concerned that this will harbor live active tumors. So this patient will need a PET scan to look for avidity, and following on from that, a biopsy to confirm this. And then MDT will likely recommend a full course of second-line chemotherapy, which could be BEP again, or cisplatin, ifosfamide, and etoposide.
What type of PET scan you will perform?
FDG PET scan.
Okay, what is your protocol for the residual mass in non-seminoma?
So for non-seminomas, if there is a residual mass, then patient goes on to retroperitoneal lymph node dissection.
Any investigations?
So there's no role for PET scan for non-seminomas. Tumor markers can be done to assess if tumor markers are still raised. If they are raised, then patients will require further chemotherapy. If the tumor markers are stable or plateaued, then patient can go on to have RP-LND.
Is there any size criteria below which you can avoid RP-LND?
1 to 2 centimeters.
Okay, 1 centimeter.
1 centimeter.
Anything less than 1 centimeter you can observe. The scenario is complete now. So anything less than 1 centimeter you can observe. There is a 9% recurrence chances, but anything more than 1 centimeter you need to do bilateral RP-LND. And RP-LND is the primary choice compared to chemotherapy. And as you said, there is no role for FDG PET in non-seminoma.
Yeah.
Usually, at least 6 to 10% of these residual masses contain active cancer. 50% may have post-pubertal teratoma. 40% will be only like a necrotic fibrous tissue.
Yeah.
And taking you back, I'm quite happy with your international germ cell collaborative classification. You try to nail it as much clean as possible. The primary RP-LND is for teratoma, and instead of saying just teratoma, you can say teratoma with somatic malignant component in the testes.
Okay.
So TSMC. So if there is a
Okay.
teratoma with somatic malignant component in the testes, we need to plan for primary RPLND since teratoma
Okay.
is not amenable to chemotherapy.
Okay. Yeah.
Any stage 2, try to divide it into S0 and S1 because both are in stage 2, and then
Okay.
based upon the S0, S1, you can take it forward. And IgCCG, as you said, using the testicular tumor markers are very important. And I'm quite happy, as I said, you are divided into non-seminoma, into 3 groups and seminoma into 2 groups. When you are saying that, you need to mention that in seminoma, it is irrelevant what the tumor markers are. Whatever
Yeah.
the tumor markers, it all depends upon whether there is pulmonary, non-pulmonary visceral mets present or absent. That's the main thing, differentiate between good and intermediate prognostic group. Okay,
Yep.
good. So overall, in my view, you can divide the whole testicular cancer gambit into 3 sections. The first
Okay.
section is the preparation of the patient, testicular tumor markers, examination, as you said, taking the patient by the foot into the scan machine, and initial staging of CT scans and preparing for orchiectomy. And the second section is like, how will you do orchiectomy? Why high inguinal orchiectomy? How are you going to secure the cord stump? What is the role for testicular prostheses? What is the role for opposite testis management in case if it is synchronous or metachronous tumor or solitary tumor? That is the
Yep.
second group. Third group is purely oncological. So once the histology comes, usually in our practice, as you know, the MDT will refer the patient to a tertiary testicular cancer SMDT, and usually
Yep.
they will take care of the retroperitoneal imaging, chemotherapy. Of course, if there is a need for RPLND, it will fall back to a urologist if the particular urologist is having a special interest in RPLND, but
Yep.
mostly it will end up in the hands of the retroperitoneal sarcoma surgeons who have more volume and more expertise.
Okay.
So in these
Yeah.
3, the part 1 by 3rd of first and second are very important, and I'm happy you're quite strong in all 3. The third 1 by 3rd, the last fag end, is little bit very memorizing thing, and you just have to
Mm.
clearly, nicely plot it out, write in a clean A4 sheet. It will take like 1 by 4th of your sheet. What is the plan for the last 1 by 3rd of the section? First
Yeah.
2 1 by 3rds will be easy to understand. That's what we do day in and day out.
Yeah.
Usually in the exam, your 10 minutes will be, we have done 30 minutes dividing in the 3 parts series. Usually in the exam, the first 2 parts itself easily take out your 9 minutes of your section if you're fast and the examiner really wish to push you forward without discussing TNM staging, without discussing IgCCG staging, and you end up in a very high level discussion. So the last
Okay.
1 minute only you will be touching this last 1 by 3rd. You're at good stage, so if you're able to mug up and bring out the main indications for RPLND, the peculiar things like teratoma, the peculiar things like absence of FTG PET for indications in non-seminoma, if you're able to bring out those things, that's it. You're
Okay.
encashing the full testicular tumor scenarios in an absolute full mark.
Thank you.
Okay?
Thank you.
Yeah, as I
I
said,
got slightly confused when you asked about stage 2A,
yeah,
but I then realized that actually it's the full staging, combining the TNM to
yeah,
get the stage 1, 2, and 3. So it took me a bit of time to understand the question, but
yeah.
I later on realized what you were asking.
Yeah, because if it is like the discussion based sessions like how we did 5 weeks back or 1 month back in the starting stage, I can give you some clues. I really want to keep my mouth shut like an examiner
Yeah.
so
Yeah.
that you
Yeah.
have the real time experience for the 10 minutes, and then later I can help you with any clues and etc.
Yeah.
So overall, the testicular cancers are very straightforward. First 2/3 of the section will go exactly same way, then it will divert based upon the histology of seminoma or non-seminoma, but by the time you'll be easily at 9 minutes. So understand the protocols for seminoma and non-seminoma, stage 1, stage 2, and bring in the IgCCC staging, and then you can sail through. Mostly you won't be able to bring out the so many things we have revised and read, but that's how it has
Yeah.
to be. your knowledge should be more than what you are able to express on the day. So that
Okay.
the examiner should feel, okay, he has spoken for the 10 minutes, but I know he know more than what he has spoken. That confidence you
Okay.
should give it to the examiner.
Yeah.
Okay,
Yeah.
that comes with using less words and using a very swift, clean answers. I'm quite happy with your communication and application of the knowledge. That should give the examiner a confidence. Okay, this guy is good. There is no point in asking TNM stage. Let's just go to the next one. If I
Okay.
ask IGCC staging, he is going to really take next 1.5 minutes explaining the poor, intermediate, and high risk, and then I know he knows. Let's go for the next one. That you should see that examiner's pace pushing you to the last 1/3 section. That's where the victory lies.
Yeah. Yeah. Okay. Yeah.
Very good. Any other feedback from yourself?
No, I think this is very useful. I think we've covered the whole breadth really of testicular cancer, and the third part, which is the oncological bit, is clearly what we don't tend to do.
Yeah.
And even in MDTs, you know, it's the oncologists who sort of champion the discussion.
Yeah, and usually they will take it onward. Unless if you are really in the testicular cancer SMDT, you won't even hear the actual clear discussions.
Yeah, absolutely. Yeah.
Good.
But that's very useful. I think we've covered the three possibilities. So hopefully the exam goes well.
Should be. And as usual in the YouTube, you can see the clear slides. So when you are revising using the YouTube, try to pause and get the maximum out of the slides. We should really thank Anish, who has done all the hard work of preparing the slides.
Yeah.
And if I cover the slides completely, it will be easily 5 or 6 scenarios, but 3 10-minute scenarios is more than enough to cover. If you guys are interested in a little bit more beefing up, I think the slides in the YouTube will really help you. You don't have to really refer to everywhere.
Yeah. Thank you so much. Thank you. Very helpful.
Good. Have a nice rest of the day. I will catch you back
too.
in next few days' time.
All right, you too. Thanks. Bye-bye. Bye now.
Cheers. Bye.